The importance of prompt intervention, unexpected acetaminophen and NSAID-induced liver injury. Our learning objectives are to recognize the signs and symptoms of acetaminophen and NSAID-related ingestion in patients who are unable to report a complete history, to understand the adverse effects of acetaminophen and NSAID-related ingestion, and to review the management of acetaminophen and NSAID-induced ingestion. Our case includes an 81-year-old female with past medical history notable for hypertension, type 2 diabetes mellitus, hepatitis B, dementia, and osteoarthritis, who presented to the emergency department with concerns of lower mandible pain and melena. History was limited due to the patient's history of severe dementia. On admission, the patient appeared encephalopathic, however, was able to answer questions. Further history revealed that the patient took approximately 10 to 15 grams of acetaminophen in the last 2 days, as well as an unspecified amount of aspirin and naproxen. Per family, the patient had potentially taken many pain medications at home for new onset tooth pain. However, the number and type of medications was unknown. Lab values on admission were notable for AST of 2,502 and ALT of 3,729. Hepatitis B core antigen was positive, however, Hep B DNA was undetectable. This graph shows AST and ALT versus the days since presentation. AST and ALT both trended down consistently following admission. Labs were also notable for a urine drug toxin screen that was negative, a Tylenol level of 7 without concomitant metabolic acidosis. INR was elevated at 1.7. Liver ultrasound demonstrated normal echo texture of liver parenchyma without hepatic mass. Given concern for acetaminophen ingestion, the patient received N-acetylcysteine, continuous IV pantoprazole, 1-liter bullets of normal saline, and vitamin K. EGD revealed LA grade A esophagitis, a non-bleeding linear gastric ulcer, and diffuse inflammation. She was managed with maintenance pantoprazole therapy for a total of 6 weeks. AST downtrended to 28 and ALT decreased to 62 1 week following presentation. When acetaminophen ingestion is suspected, emergent evaluation and intervention via N-acetylcysteine and activated charcoal has the potential to halt biochemical damage. In our patient, elevated liver function tests were thought to be multifactorial in etiology. Negative acetaminophen level was attributed to acetaminophen's rapid half-life. We urge providers to be vigilant regarding suspicion for acetaminophen and NSAID-related overingestion in patients presenting with pain concerns. This case highlights the importance of eliciting a thorough history in patients with dementia and recognizing the clinical variability in presentation with the acknowledgement that following rapid ingestions, patients may be asymptomatic.